everyone, welcome back to another episode of ResearchWorks podcast. We're here with our conference series, EACD Galway, Ireland 2026. Sitting next to me is a friend of the show, Wade Schrader. Thank you so much for joining me once again.
Oh, thank you so much, Dana, for having us. I enjoy being on here talking with you. It's so much fun.
It's so good. I think we've managed to speak in the last few conferences now.
Right.
And soon I'll be going to the US, so I'll be able to join you on your own turf.
We're so excited to have you there. We can't wait to host you there in the United States. Yeah.
Oh, can't wait to be there. And I'm sure your team, like I've been looking through the program, your team is presenting a lot within this conference. You must be so proud of the work that's getting out there and being shared with the world. I
am so proud of them. We have an incredibly deep team from our physical therapists and our gait lab to the other orthopedic surgeons. And then, for some of the things that I'm presenting actually represents research coordinators, pulmonologists, our engineers, and so I'm very proud of our group.
Yeah, it's wonderful. Absolutely. And for someone like me that looks through the program schedule and goes, oh, who would I like to talk to about what topic? And I saw this one and went, Wade Schrader, this is what you're presenting.
Yeah.
And it is fascinating. So I thought we'd talk about this one. It is titled Non-invasive Measurement of Work of Breathing in Children and Young Adults with High-Level Cerebral Palsy.
Yeah.
How did this come about?
So this is really a significant clinical problem. Kids who are at the GMFCS 4 and 5 level, many of them have restrictive pulmonary disease. They have pulmonary complications. We all know that.
Yeah.
Sometimes they have it from bronchopulmonary dysplasia from the NICU. Yeah. Other times it can be restrictive lung disease from scoliosis. But because those kids, they can't really go through formal pulmonary function testing. That requires you getting in an enclosed volume space. Yes. It requires a lot of selective motor control in expiration and inhalation, and so inspiration. So those kids just never could do those testing. So there's a missing gap there of how we objectively measure data about their pulmonary function. And so that's where this came about with the help of one of our ingenious engineers back at DuPont and Nemours.
That's fantastic, because one of the studies that we've been involved in, and there's some children that get involved in their GMFCS level 4, it involves lip closure, because they have to be able to breathe through a device.
Yeah.
And they can't do it.
They can't do it.
They can't close their mouth around it.
They don't have the strength or the selective motor control to probably do it,
right. And so, and even if they could do that, the coordination it takes to actually get an accurate assessment of their lung function.
On demand.
On demand.
Right. Say, okay, now I need you to fully breathe out and fully breathe in. Yeah. They just really can't do that.
It's so true. I mean, in Australia, we have, do you guys have this in the US? We have breathalyzers. The police will stop you.
Oh, yeah.
And as I drive through, like, I don't drink, so I'm never worried. But what I am worried about is whether I'm too nervous, whether I can actually breathe through the device. And the police usually come to like, you've got to blow out really hard, ma'am. And I'm like, I'm trying to, okay.
Yeah. I'm sure you'll be fine. I'm sure you'll be fine.
But there's a lot, right? There's the performance element.
There is a little performance element to it.
Yeah.
And then kids that have, any type of intellectual disability, it's hard for them to follow. There's just a lot of reasons why
to get to a very important assessment.
To get to a very important assessment, right? So that's where this came. That's the root of why we started looking at this.
And from your perspective as an orthopedic surgeon, why is this important for you in particular? Like, how did you get involved in this?
Yeah, so, I mean, we are very intentional when we're planning a big operation, whether it's a hip reconstruction, a big semials, or especially a spine fusion. We know these kids, GMFCS 4 and 5, have a lot of medical complexity.
Yeah.
We know they're at risk. Probably for spine fusion, the number one complication is a pneumonia or a pulmonary complication. So we go through a very deliberate care coordination, preoperative care optimization program.
Right.
But we don't really have a lot of data on the pulmonary side of it, right? We do some sleep studies to see if they have sleep apnea, whether they need BiPAP. Obviously, if they have pulmonary disease, they're seeing the pulmonologist. But like I don't have an ability to kind of grade how severe their pulmonary function is in order to help the family understand the risks behind a scoliosis surgery.
Sure.
So that's where this kind of came about.
I see. The surgeries are quite long, aren't they?
Yeah, they can be. Like the scoliosis surgery can be 6 hours long.
Okay.
And so that amount of time under anesthesia with IV fluid, they can get pulmonary edema, they can get a pneumonia. That's the most number one complication after spine fusion.
Okay.
So
what did you do? What does this look like?
Yeah, so it's a pretty simple device. It's a plethysmography type unit, which has these straps that go across the chest and around the abdomen. Think a lie detector test. Okay. That's exactly what it's like. It's exactly what it's like. It measures your breathing rate, but it also measures how much you're breathing out of your chest, out of your chest wall, and how much you're belly breathing.
That's important. Yeah.
And so, like for us who are neurotypical, we coordinate the movement of our chest wall muscles and our diaphragm. So those things are in phase.
Yes.
But for children with significant pulmonary disease or a disability, a motor disability, those things are out of phase.
Right.
So they're breathing faster. Yes. They're out of phase. And from that, we can measure work of breathing and like a labored breathing index and a phase angle. And those are kind of the surrogates that we're using for pulmonary function testing.
Fantastic. Okay, so then how did you test it in this particular group of young adults?
Well, the first group that we tested in was in kids with Duchenne's muscular dystrophy and SMA. Okay. And those kids early on can do PFTs. Okay, yeah. So we were able to kind of correlate and show that, they're measuring different things. PFTs measure lung volumes directly, but they actually were correlated.
Okay.
So we were able to validate it, and we're still using that in our muscle clinic.
Sure.
But then the idea was, let's try it in this population. So we were fortunate to get an NIH grant for this. It's a pilot study. Yep. We did 150 patients. Wow. It's very easy. You do it in the clinic. Yeah. They're sitting there in their wheelchair. You hook them up to a pulse ox. You put these straps on. You let them breathe normally for 5 minutes. It wirelessly goes down to an app, which you can kind of see the plots immediately. Oh,
I love that.
And then it just goes into our database. And so then we've been able to analyze that. And so we've been able to, some of our patients we've followed over time. And what we showed was that we also can detect pulmonary disease. So the kids that we have known pulmonary disease, those indices show higher indices. They work harder. They're more out of phase. Right. We also were able to discriminate between 4s and 5s. Our 5s actually work a lot harder breathing. Yeah. Not surprising. That's right. But this validates this tool potentially to be able to be used. So exciting. So that's what we presented yesterday.
That is fantastic. And so do you see this being used beyond, this clinical setting, preparation for surgery and understanding what they are looking like? Like, can it be used?
Yeah. I mean, I think it could be used as a screening device because, this will likely be pretty sensitive. Maybe they haven't been diagnosed with something yet from a pulmonary perspective. They haven't seen a pulmonologist yet. Yeah. This could be used as a screening device for that. It could be potentially used to measure effectiveness of treatments. Yeah, for sure. And then finally, our next big thing that we're going to look at is we're going to see if it correlates with their scoliosis. Wow. Because you would think as the curve gets bigger, their restrictive lung disease gets worse. Yes. Then their indices should also get worse. Yes. And then finally, does our spine fusion make that better? Yeah. Anecdotally, I've had patients that were oxygen dependent before their spine fusion. Sure. That didn't need as much oxygen afterwards. Wow. Right? Because it kind of makes sense that everything's more aligned and it should work in phase maybe a little bit better. Yeah. That's kind of the ultimate end goal of this. Oh, that's fantastic. So, and I love that. It's non-invasive. It's something that you can integrate into clinical practice really easily. Totally. While they're waiting to see me, while I'm finishing up with another patient, my coordinator goes in there, measures it. It's all done by the time I get in there. That is fantastic. And families. And it's not stressful. You just put it on there. Oftentimes they're on their iPad or they're interacting with their parents. They're just sitting there breathing. Sure. And it's often done in sitting or we've been doing it in sitting. So it's been there in their wheelchair. Yeah. Or if they wanted to be supported like in their parents' lap or on the exam table, we've done that. But most of them are just doing it in their normal native wheelchair with their normal support. That is fantastic. Just measures their breathing. That's fantastic. Because when you often think about assessments, there's that assessment burden, isn't there? Here we are, something else to ask you, and to have something that you can, take so easily straight into your clinical practice. And it'd be really interesting,
I wonder whether it would be really validating for our young people, what they're trying to describe about their work of breathing even. Because we often have our scales, we'll show them the scale. We'll go, okay, this 1 to 10, how does it feel? It would be interesting to know.
Yeah, what their perception is. I think that's a great idea. We should put that in our next grant, right? Because then we can have those kids that are able to communicate with us and tell us, see what they think.
Yeah,
and
that's
then correlate, see if that correlates. We could ask their parents too, what they feel like, how much they struggle breathing.
And I can't help but to think about when we talk a lot about physical activity. There's a keynote about that, and it always shocks me when the goal is to be 60 minutes physical activity per day, and we know how hard that is for GMS level 4 and 5. And we're doing a project to kind of go, can we just increment it per week by 10 minutes? Let's make it manageable. Just a bit would be great, right? We're just replacing sitting, but we want to get them to a point where they're slightly out of breath.
Yeah.
I wonder whether you could use it as like an exercise measurement
I think you might could. And actually somebody else has come up to me asking that exact question about taking 4s and putting them in like frame runners and using this device to kind of measure before and after.
Yeah.
So
it'd be really interesting.
Yeah.
God.
We measure pulse ox while we do that too.
Sure.
So, it's a very easy, very portable sort of way.
So how can obviously studying this is a part of an NIH study. How do other centers, I'm sure people are listening going, wait, I want some of that. Come on. I've already gotten 2 emails this week saying, how can we get that? So my engineer has the patent. Okay.
But we haven't commercialized this yet because it's really we've just been doing this here at our own site. But we weren't even sure whether it would really translate from the muscle kids over to kids with CP. So we've been very pleased with the results, almost a little surprised by them.
What happens when you come with a good idea?
Yeah, good idea, good engineer. So I'm looking forward to getting back to the States to talking to Tarek. Tarek is an amazing engineer, right? Saying, what are our next steps? So I've been really kind of thinking about, okay, what's the next grant application? Because I think trying to see how we operationalize it a little bit to your questions. How do we use it for pre-op optimization? How do we use it to measure effectiveness of spine fusion? That's what I've been thinking. I haven't been thinking about that.
Like GMS's curves, like you've done for hips, and you kind of...
Well, that's exactly what it is for 4s and 5s.
Yeah,
and we probably should test it for 3s too. That's right.
Yeah. So now there's more work to do.
Yeah, there's more work to do. Always more work to do.
Yeah. While I've got you, because, all things orthopedics, I do need to ask you a question around just where do you think, where's the state of the evidence at the moment, where the work is, what are you most excited about when it comes to orthopedic surgery in cerebral
I'm happy
palsy?
to talk about that. I feel like we have really pretty good evidence, maybe not in the green light, red light, yellow light scale from like a randomized clinical trial. But I know our spine fusion, our hip reconstruction, I have really good indications and feelings that we're doing right by our patients for that.
Yeah.
But I think some of our gait surgeries, the indications are a little softer.
Yeah.
And especially, I think really looking at how effective are we in improving what's important to families with long-term outcomes from gait intervention, especially hamstrings, flex knee gait.
Yes.
To me, that's the theme. I think a lot of those adolescents, when they get to that adolescent growth spurt curve, they kind of start to crouch a little more. They lose some function. They lose some participation. And so how we can choose surgically which kids we can most benefit from. Because when we hit a home run, it is amazing.
Yeah, sure.
But I know there's a lot of kids that it's probably not as clear in their outcomes for. So I think really trying to get into that from the family's perspective, that precision medicine, right? I said that all along. Precision medicine, we think of genomics
we do often.
And chemotherapies and things like that. But I would say our gait laboratories were doing precision medicine 20, 30 years ago, right? We talk about symbols, and you and I have talked about this before, as a single entity. No two symbols are exactly alike because there's this menu of 30 different procedures that we pick and choose based on that diagnostic matrix of exam, imaging, and gait analysis. So
it's exciting, isn't it? And I don't know, every time we've spoken, I think I've asked you the same question, and I love that each time it's like more precise even then, like in terms of where we're headed. It's really exciting time.
I think so. And I think, and how that goes, how those changes from that pre-adolescent growth spurt to late adolescent that we know there's some decline, what can we do surgically to try to help that?
That's fantastic. Wade, I've been asking everyone this question at the end of every single podcast episode, because this is a very F words themed
F words everywhere. Right, that's exactly right.
All the good ones.
All the good ones,
So what would your advice be, Wade, to clinicians to implement more F words into their practice?
Yeah, that's easy for me.
Yeah?
I think it's family.
Family.
I really think it's family. I think, just as what we were just talking about, we measure outcomes based on what we can measure.
Yeah.
Right? We can measure kinematics in the gait lab. We can measure x-rays.
Yeah.
But really, I really try to encourage all of my team to really pivot that around and think about what it's like for all of our interventions, what we're recommending from the family's perspective.
Beautiful.
And, as Peter Rosenbaum said, maybe it's not the medicine or the surgery that we do, but it's how we embrace that family and walk them through that journey, which is the most important thing.
It's so important.
Yeah,
I love that. And I think we've spoken about it before with other people where we're like, there's the technical skills and the knowledge, so important, but what bridges the gap is those soft skills, those relational, because when you have those, it's a trust relationship at that point, isn't it? And you can work on the solution together.
Well, and we know, it's hard being parents. It's hard in general, but we know that the families of our children who have disabilities, their well-being's impaired, right? Yeah. And society doesn't help that, right? So there's a lot, they're stressed a lot.
Yeah.
And so I think anything that we can do, any extra efforts that we can do to try to help them along in that way from the psychosocial perspective is really important.
That's fantastic. Wade, thank you so much for joining us again.
Thank you, Dana. This was a blast.
I loved it.
Thanks so
I absolutely loved it.
Thank you.
To all of our listeners, I hope you really enjoyed that. Again, another perspective, but really important. And so if you're interested in this device, contact Wade.
Contact me. That sounds good.
That sounds really good.
All right.
Join us again for more episodes for sure. Hope you all really enjoyed it. Thank you so much. Bye.